This is our second month. We do it monthly. Today, we have two specific papers that we will be covering. Our basic science paper is from UCSF, is the perivascular delivery of resolvin D1 inhibitors, inhibits neointimal hyperplasia in a rabbit vein graft model. And our clinical paper is from UC San Diego, and is titled Increased Mortality with Paclitaxel-Eluting Stents is Driven by Lesion Length. We're fortunate to have our two host organizations. From MUSC, Dr. Elizabeth Genovese will be discussing or introducing the paper, and her resident, Dr. Ryan King, will be discussing it. They will be taking on the basic science article. You know, the stronger team gets the best article. So, and from Michigan Vascular Center, Dr. Mark Mattos, and who is a faculty member there, will introduce his article, and Dr. Khan, his first year fellow, will discuss it. So, in addition, we have our special guests from UCSF, the authors of the basic science article. Beyond Wu is the first author. He is a vascular surgeon now at Kaiser Permanente in San Francisco. And Dr. Michael Conti, who has graciously been able to join us as well, who is the E.J. Wiley Chair and Professor and Chief at the Division of Vascular and Endovascular Surgery, as well as co-director of the Heart and Vascular Center at UCSF. From UC San Diego, again, we have the first author of the clinical paper, who is a second-year research fellow at the University of San Diego. Asma is joining us, and her mentor, the senior author, Dr. Malas, who is also professor in residence, vice chair of surgery for clinical research, and chief of the Division of Vascular and Endovascular Surgery at UC San Diego. Just a couple of housekeeping notes. Please mute your microphone and stay muted. If you have a question, you can type it in the chat. The discussants will call on people sometimes, but a lot of times we'll go through the questions that are in the chat. The event will be recorded so that we can provide on-demand access. And of course, we have the March JVS Journal Club, which will be coming up on Wednesday, March 10th at 6 p.m. Eastern. That is being hosted by Maine Medical Center, Dr. Blazik, and also from Carolinas Medical Center, Dr. Briggs. So with that, we'll get started with our first paper. So.
Well, thank you, everyone. Let's see here, we'll get started. I hope everyone's having a fantastic night. Thank you, first of all, to Dr. Humphreys and Dr. DiMuzio for giving us this invitation to talk about and discuss this very topical basic science paper. So the topic we're going to be discussing today is the perivascular delivery of resolvin D inhibits neointimal hyperplasia in a rabbit graft vein model. And this is work done by Dr. Wu and Dr. Conti. So we all know what the clinical problem is in our peripheral arterial disease patients. PAD is incredibly prevalent in the United States, and as people get older, this is going to become even more of a national problem. Over 8 million Americans carry the diagnosis of PAD, and we know that along with medical management, patients with severe lifestyle-limiting claudication symptoms and those with chronic limb-threatening ischemia are often going to require revascularization of some sort. And while we have many advances in our endovascular technology and treatment modalities, a standard arterial bypass with vein graft conduits still remain a durable means to provide revascularization, particularly to our patients who have advanced task lesions. What we know is that vein bypass conduits undergo a degree of remodeling that is associated with the arterialization of the vein once it's hooked into our bypasses. The patency of these bypasses can definitely be threatened by a persistent inflammation process that is associated with the remodeling and leading to neointimal hyperplasia, stenosis, and possible even graft occlusion. This chronic inflammation and neointimal hyperplasia also contributes to underlying atherosclerotic disease and restenosis after endovascular arterial events. So methods targeting inflammation reduction to prevent this neointimal hyperplasia are a major area of clinical and research interest. Specialized pro-resolving lipid mediators are a naturally occurring mediator that occurs in our body every day that limits acute inflammation. It brings about inflammation resolution, but more importantly, it does this without impairing the host defense as compared to some other inflammation treatments. It's derived from omega-3 fatty acids, and what we've seen in literature has been described for the E series and the D series resolvins. What Dr. Conti and others have proven in the past is they've demonstrated the ability to attenuate inflammatory pathways and vascular smooth muscle proliferation using these the SPMs. Particularly, they've also looked at resolvin D inhibiting inflammation and intimal hyperplasia. So with that, Dr. King, one of our chief residents here at MUSC, is going to discuss the paper where the goals of this is to demonstrate the safety and the efficacy of local delivery of perivascular resolvin D in vein graft models in order to provide evidence of the vascular protective effects of the specialized resolving lipid protein mediators, and also to demonstrate the utility and prevention of neointimal hyperplasia. And with that, I'm going to give the screen over to Dr. King.
All right. All right, so I'm going to run through some of the data and the specifics of the study. The perivascular delivery of resolvin D inhibits neointimal hyperplasia in a rabbit vein graft model. And as Dr. Genovese kind of already went through quite a bit, to start off with just some background, we know autologous vein bypass are durable options for those with severe peripheral artery disease. However, inflammation, which subsequently results, leads to neointimal hyperplasia, and that ultimately impacts the intervention durability. The specialized pro-resolving lipid mediators, like resolvin D, in which Conti and others studied in this specific article, are biosynthesized polyunsaturated fatty acids, and they've been shown to orchestrate the process of inflammation resolution while enhancing host defenses. And a lot of the prior studies that were done on SPMs, that show that they attenuate neointimal hyperplasia in animal models, may also promote revascularization of ischemic limbs. Some of the delivery methods, however, in these prior studies may not be necessarily suitable for those in the clinical setting. The perivascular delivery of SPMs like resolvin D may allow greater pharmacokinetic efficacy and ultimately limit inflammation and subsequent neointimal hyperplasia. So with that in mind, with the idea that inflammation drives neointimal hyperplasia in vein grafts, and the specialized pro-resolving lipid mediators may facilitate inflammation resolution, Conti and others went out to answer the question, does the perivascular delivery of resolvin D1 decrease inflammatory markers, collagen deposition, and cell proliferation in rabbit carotid vein bypass grafts? In order to do this, the team constructed 3 different delivery constructs for administering the resolvin D. The first one is a thin polylactic co-glycolic acid, or PLGA wrap. And this is a biodegradable wrap. It provides sustained unidirectional release of the resolvin D when applied to the vein grafts. They also use another delivery system, which is a pluronic F127 gel, and their vehicle construct, which in this study kind of functioned really as a control. So this is an electron microscopy image of the RVD1 construct, and you can see here that there's kind of different percentages of PLGA, and that facilitates unidirectional release of the resolvin D once it's within the wrap. And then in vivo, you can see here the vein wrap and then the pluronic gel in image C. So the subjects that they specifically used, these were New Zealand female white rabbits. They had a total 80 included within the study. And the 5 study groups that they had was the bypass only group, which was one of the controls, the vehicle gel, the RVD1 gel, the vehicle wrap, and the RVD1 wrap. The vein bypass grafts were reverse left internal jugular veins that were harvested from the rabbits. and they were used as interposition carotid bypass grafts. The team used many different outcome measures within this study. The first one being liquid chromatography tandem mass spectrometry. They looked at that in 3 days to assess the delivery of the RVD1 to the vein bypass grafts. They used immunohistochemistry at 3 and 28 days to quantify the presence of inflammatory cells. Reverse PCR was done at 3 days for gene expression of inflammatory markers and genes that specifically were genes that led to the expression of certain proteins that enhance inflammation. They also used prophometric and collagen analysis at 28 days to really assess for the amount of collagen deposition after a longer period of time in these bypass grafts. And the statistics that they employed, they used pretty standard statistics, one-way ANOVA test, two-tailed student t-tests were used for comparisons, and then individual comparisons using Bonferroni corrections. So looking kind of at their bypasses grafts that they harvested at 3 days, they used their liquid chromatography, mass spectrometry, and that confirmed the presence of RVD1 within the vein bypass at 3 days. And you can see here the RVD1 within the bypass graft was significantly elevated compared to the vehicle control. And then looking at leukotriene B4, which is an inflammatory marker in this study, they measured that at 3 days. And the vehicle construct, which was the control, had a significantly higher, degree of leukotriene B4 compared to the RVD1. So looking at other inflammatory markers in the early phase, so this is again harvested at 3 days. RVD1 in both forms showed significantly less infiltration at 3 days compared to the bypass only group and its respective vehicle constructs. So that's shown here in figure A, and this is just leukocyte infiltration. The other cell type that they studied at 3 days was macrophage infiltration. So looking at the inflammation response in both cell groups, the RVD1 seemed to provide significantly less infiltration compared to the bypass only. But macrophage infiltration was really most significant in the RVD1 gel. Looking at gene expression, there was really no significant effect on gene expression at 3 days, looking at the target genes that they looked at in this study across all different treatment groups. Cell proliferation, they studied using this Ki-67 index. And you can see here, again, the RVD1 gel and RAP performed significantly better than the control groups with significantly less cell proliferation when harvested at 3 days. The study did mention, however, at 28 days, so if the vein bypass was harvested later on, there was no significant difference between the groups that received RVD1 versus not. Neutrophil apoptosis, which is really a characteristic feature of the transition to the resolution phase of inflammation. This was studied using the tunnel positive nuclei. And if you look at this graph down here, you can see clearly that the RVD1 gel in particular had a significantly higher rate of apoptotic nuclei. So the neutrophils were undergoing apoptosis at a significantly higher rate in the RVD1 gel group compared to the other 3 groups. So a lot of those were the 3-day results. So looking at the 28-day host response, you can see here that the RVD1 gel, looking at the leukocyte infiltration at 28 days was pretty low, and it was also low in the control groups as well. Whenever they used a RAP at 28 days, there was a significantly higher rate of leukocyte infiltration, but the RVD1 treated RAP still performed significantly better than the vehicle RAP or the control group. And macrophage inflammation showed, again, a very similar trend. So there wasn't a whole lot of inflammation in the bypass only group and just the regular vehicle gel. The RAP, for whatever reason, which they kind of get into their discussion, was associated with a higher infiltration of macrophages but the RVD1 was able to show a significantly decreased inflammation response. Looking at collagen deposition, which is really a measure of neointimal hyperplasia, the group did this at 28 days, and RVD1 showed less collagen than the deposition than the vehicle constructs in the control group. And that's really demonstrated here in F. The trichrome staining is the measure of collagen, and the RVD1 gel and wrap had a significantly less collagen deposition than their respective control groups. However, when looking at lumen radius within these bypass graphs, there was no significant difference between the two groups. So discussion, RVD1 delivered to rabbit vein grafts at the time of implantation via gel or the film reduced neointimal hyperplasia at 28 days by 50 to 61% compared with the bypass-only controls. How did it do this? SPMs decreased leukocyte endothelial cell interactions, potentially through the upregulation of endothelial cell nitric oxide production, and decreased expression of adhesion molecules on both leukocytes and endothelial cells. Attenuation of growth factor stimulated smooth muscle cells has been observed in vitro, as well as anti-proliferative effects have been observed in vivo. So it appears that the RVD1 attenuates the early inflammatory migration and decreases the inflammatory cell proliferation and enhances neutrophil apoptosis. It didn't seem to have any effect on gene expression at 3 days. And at 28 days, RVD1 was shown to significantly decrease the amount of collagen deposition within these bypass grafts. In conclusion, the perivascular delivery of RVD1 using either a gel matrix or a biodegradable film significantly decreases or attenuates the neointimal hyperplastic response in a rabbit model using autologous vein bypass. Therefore, SPMs may eventually be used in the clinical setting to prevent restenosis and bypass failure. Thank you.
Thank you, Dr. King. I want to encourage everybody to put your questions into the chat. There's a couple of them there, but before we kind of get to those, Dr. Conti, I was wondering if you could talk a little bit about the model that you used. I mean, is this rabbit model, is 28 days adequate time? Do you need to do longer studies in this model? Or Dr. Wu, one of you?
So it's a fairly standard model for translational work with neointimal hyperplasia. I just want to take a second to thank Dr. Conti for letting me be a part of a much bigger project, and this is an ongoing project with now an ovine model that's the explants are at further time points. We chose 28 days and 3 days. Just, you know, some authors choose 14 days. Some, you know, you could go out to 60, but we you know, somewhat arbitrarily chose those time points. They're fairly standard, but certainly more data is better.
Yeah, thanks, Bjorn. I guess I would just echo that, you know, the study really just extends the information we have that these compounds have vascular protective properties, but it's still a pretty early kind of preclinical model and a short-term experiment. You know, longer-term experiments in either an atherosclerotic model and or a larger animal model, which is where we've gone now up to doing studies in sheep, which are still being finalized. And one of the main challenges for this work is trying to develop optimal formulations that have good stability and are easy to work with and deliver on devices potentially. Developing sort of oral analogs for these compounds is a bigger challenge, but they're very well suited to local drug delivery. But we need the most optimal formulations and to understand the pharmacokinetics better.
So Dr. Glavitsky put in here a question that I also have a little bit of a question, the same thing, which is an AV fistula in a rabbit not a better model to study intimal hyperplasia? And that kind of correlates a little bit with my question. Your models were end-to-end anastomoses. Is an into-side anastomosis, which is what we do a lot more, is that a little more prone to intimal hyperplasia in these models? And should we be doing something more like that to really study this thoroughly?
Yeah, great points. So this model is really not a stenosis model. And actually, almost all the bypass models in animals are not really models of graft disease. They're really just models of arterialization. And we kind of make the assumption that if you can moderate the arterialization thickness, that it will translate into preventing graft stenosis. But that's not necessarily true. Creating anastomoses just adds a whole nother technical kind of challenge to the measurements. So we decided for this phase to focus on the neointima that forms in the middle of the graft as a surrogate, for possibly downstream graft disease. But those are great points.
And Dr. DiMuzio wants to know how you take this sort of from bench to bedside and what's really necessary to get this into a clinical trial besides money.
Yeah, thanks, Paul. First, I'll make a disclaimer because I do have some intellectual property involved in this. But we were fortunate enough to get funding from NIH for moving into large animals through a special NIH contract program. And as I mentioned, we're focusing on first looking at some other stable analogs that might have longer biological half-life, and then two, moving into a larger animal model. And those two things together, even in this early preclinical development, have required a significant investment, about $1.5 million over the course of the last few years. If it's going to go forward, it needs both. It needs a small company really to leverage developing the chemistry into formulations that would work on different devices, and additional large animal studies leading up to an IND first in man. Be a couple more years and significant more in resources.
Thanks, Michael. You mentioned on the chat too, you were also thinking, endovascular therapy is more common than bypass therapy now. I'm sure you're thinking broadly, and the next paper is about what we coat stents with. Are you guys also thinking that as well?
Yeah, no question. I mean, certainly the paclitaxel controversy also has been an issue. Even without that, we know we could use some new drugs that can reduce inflammation without killing cells and without toxicity. And, everyone's looking for new leads in that direction. It's a matter of both adequate potency and whether or not these are compounds that are easy to work with. And, but I think that's the real reason that we're interested in this area, is to provide some new potential drug candidates for devices.
Fantastic.
Well, thank you both. And that will bring us to our clinical paper, which is going to be introduced by Dr. Mattos. And I believe I have his slides up here for him. And we can go ahead and move forward with that.
Misty, will I be able to move these, or will you move them for me?
I'll move them. If you want to tug on your ear, that'll be the signal, okay? I'm just kidding. You can just say move forward.
Okay. Welcome, everybody. Number one, a great presentation by Elizabeth and Dr. King and Mike. Nice job, and Dr. Booth in the paper. Our paper today that we're evaluating has to do with the effect of paclitaxel-eluting stents on increased mortality. And we all know that the endovascular treatment of femoral popliteal disease has really become the frontline treatment, with probably estimate that it's 80% of all treatment is from an endovascular point of view. And then more recently, in the last 10 to 15 years, is that the use of drug-eluting balloon and drug-eluting stents now probably accounts for nearly 40 to 50% of those treatment options simply because of increased patency at 1 to 2 years in both randomized trials and individual institutional studies, and decreased target lesion revascularization attempts. Unfortunately, while it all seemed it was great news and everything was moving forward and everybody wanted to use drug-eluting devices, a radiologist, Dr. Kansanos from Greece, looked at a systemic review and meta-analysis of the randomized controlled trials that were actually in progress at that time or finished, of which there were 28. And he came out with a paper that was published in the Journal of American Heart Association on December 6, 2018. He had noted that there was an increased mortality signal in some of the trials he was reviewing. And so he put together the meta-analysis. And it was a loud shock heard around all physicians who were treating peripheral vascular disease, particularly in the FEMPOP area, with drug-eluting devices. What he found was that all-cause mortality with these devices at 1 year was the same when he looked at the 28 studies and 4,600 patients. But by the second year, the mortality signal had changed, and it had showed an increase in the paclitaxel devices versus the control bare metal or non-paclitaxel devices. And for only 12 studies and 2,600 studies. And then when they took it out to 5 years, that mortality increased even more, 14.7 versus 8.1%. And they also noted that there was a higher dose associated with increased mortality in this study level meta-analysis. Next slide. So the regulatory response to this was swift and pretty significant. There was pausing of 3 ongoing randomized trials as shown there, the Swede PAD 1 and 2 and Basel 3. Clinical use was really dramatically curtailed due to the question about the risk-benefit ratio. And then there was numerous expedited safety reviews with industry of the 5 balloons and stents that were actually drug-eluting at that time. And there were cautionary messages sent to physicians in the United States, in Paris, and in Great Britain. Next. The US Food and Drug Administration's response was as follows. The first one in January 19th talked about this increased mortality, but without really an in-depth analysis, and just cautioned physicians to continue surveillance, discuss the risk, and report any adverse events. 2 months later, in March 19th, with a better evaluation of the data, they saw that there actually was a 50% increased mortality in these RCTs at 5 years, with a 20.1% versus 13.4. They still hadn't done an in-depth formal, but now recommended caution in these results, more diligent monitoring, discuss the risks and benefits, treatment options, and ensure optimal medical therapy. Finally, 3 months after that, in June, the FDA held a public meeting to discuss this in depth. And then in August 7th, 2019, they reviewed the June 19th panel meeting. And what we found was shown in red is that they did the meta-analysis in their own way. And they found that actually the crude 5-year mortality was 19.8% versus 12.7%, which had a relative risk of increased mortality of 1.57. Viva had the same sort of analysis, showed an increased hazards ratio of 1.38. Thus confirming that there was indeed a mortality signal and that we needed to take it seriously. Next. But as this came through, there were many people who were actually looking at the meta-analysis and finding significant limitations. It was conducted on a study level, not patient level. There was large variability in the risk estimates. The studies were not designed to be pooled. They're not powered for mortality, and none of them could ever define a mechanism for the increased mortality. Next. So the clinical response was absolutely an avalanche. Since 2019, there have been 47 peer-reviewed articles, which is 4 per month, and the 3 randomized trials began enrollment because none of those 3 trials saw the same mortality signal. Next. Furthermore, Peter Snyder from the University of San Francisco and Eric Samaski questioned the meta-analysis through these other surveys. And next slide. And what they found was in Peter's most recent article was that they found that there was no correlation between paclitaxel dose and freedom from all-cause mortality. They were equal. And he found no difference between the DCB and the PTA at 5 years, significantly different from the meta-analysis in 2018. Next slide. From the JAMA cardiology, they also found that there was no difference in mortality, 32.5% versus 34.3 at 600 days, which is 1.6 months. Quite a high mortality, but they had a lot of chronic limb ischemia patients in there. Next. So finally, Peter just recently in January came up with a 15-month update of all the data since the 2018 meta-analysis study in an attempt to see whether or not his review would contradict or support that original meta-analysis. Next. And what he found without getting into it is that as more long-term data became available, the RCT strength and mortality signal diminished, and that the analysis of the real-world data from a large insurance database showed there was really not an increase in all-cause mortality. His conclusion based on this 12-page summary was that they couldn't prove that there was an increased mortality, but he did recommend, like Castanos did, is that we need better peer-reviewed studies and maybe have a better way to assess the risk-benefit profile. Next. But there are questions that still needed to be answered despite all of this in the last 2 years. What patients should receive paclitaxel-coated devices? What subsets of patients are best suited? A, B, C, D, occlusion, stenotic? Is there a dose-response relationship? And then what is the optimal paclitaxel dose to maximize patency and minimize mortality? And then really, how do we reconcile all the at-odds mortality and patency data from PCD based on the 2018 meta-analysis, the 2019 to 21 reviews, and individual institutional results? So we still have a lot of questions left, which takes us to our paper that is first authored by Dr. Maluthi and senior author Dr. Malas about increased mortality with paclitaxel-eluting stents as driven by lesion length. And I'm going to have my PGY6 vascular surgery fellow, Dr. Mohammed Khan, review the data and then give us his opinion in terms of the summary and conclusion. And then we would welcome a pretty spirited discussion about where we need to go next with this issue. Thank you.
Thank you, Dr. Mattos, for the introduction. I want to thank Dr. Humphreys and Dr. DiMuzio for the opportunity to present this paper tonight. So I'll start with the aim and objectives of this study were to assess and compare long-term real-world outcomes of patients who received paclitaxel-eluting stents and bare metal stents for femoral popliteal arterial occlusive disease. It was a single institution study, retrospective case control study, and they studied all patients who underwent stenting for femoral popliteal artery occlusive disease from January 2011 to December 2017. The authors obtained the baseline characteristics as listed and patient comorbidities. Patients were from Rutherford category 2 to 6, so they range from intermittent claudication to chronic limb-threatening ischemia with or without tissue loss. The authors excluded those patients that had covered stents or concomitant drug-coated balloon angioplasty. And the included patients were divided into two groups, bare metal stents and paclitaxel-eluting stents. The stent selection was at the discretion of the attending physician. For the drug-eluting stent, they used Zilver PTX. And for bare metal stents, they use Life Stent, Everflex Stent, or Zilver Flex. Patients were followed at 1, 3, 6, and 12 months during the first year and annually thereafter. They underwent non-invasive testing such as arterial Dopplers and arterial duplex. If they identified restenosis, then they underwent angiography. The median follow-up was 23 months. The primary endpoint of the study was all-cause mortality at 2 years, and they studied the secondary endpoints of limb salvage, as well as primary assisted, and secondary patencies. The authors defined restenosis as an ABI decline of greater than 0.2 and in-stent peak systolic velocity ratio greater than 2.5, or luminal stenosis greater than 50% by angiography. As far as statistical analysis, they use the following 4 tests for continuous and categorical covariates. Survival distributions were studied using Kaplan-Meier curves. Comparison of survival curves were used. They used the Mantel-Cox log rank test, and adjusted hazard ratios of failure for procedure type were calculated using multivariate Cox regression models. And of course, it placed the statistical significance at p-value less than 0.05. So listed here are table 1, which is baseline characteristics, and table 2, which is anatomic and procedural characteristics. In table 1, there wasn't a lot of difference in the variables, but of note, the racial makeup of the 2 groups had statistical significance, as well as chronic kidney disease. There was a greater percentage of paclitaxel-eluting stent patients with chronic kidney disease. When looking at table 2, the anatomic and procedural characteristics, same thing. A lot of the variables were not statistically different between the 2 groups, but paclitaxel-eluting stent patients had greater percentage of one tibial vessel runoff. And in addition, they had more patients with greater than 1 stent placed at the procedure. Table 3 is looking at the 2-year outcomes of the whole cohort. And when you look at the primary assisted, and secondary patencies between the 2 groups, they did not find any difference. When they looked at the limb salvage, they also did not find difference. And then of note, the all-cause mortality between the 2 groups were also not significant. But when they divided these patients into task A and B and task C and D, they looked at the data individually. What the author saw for task A and B patients, when looking at primary assisted, and secondary patencies, there was also no difference. When they looked at the limb salvage, there was no difference between the 2 groups. When they looked at the all-cause mortality, although the p-value was not significant, it seemed like there was a twice the number of percentage of all-cause mortality in bare metal stent patients. When looking at task C and D patients, when they looked at the primary assisted, and secondary patencies, they also did not find a difference, although the patency in general compared to task A and B was lower in task C and D patients. When looking at limb salvage, there was also no difference between the 2 groups. But when they looked at the all-cause mortality between bare metal stents and paclitaxel-eluting stent patient groups in task C and D, there was near 4 times increase in the paclitaxel-eluting stent population. And when they calculated the adjusted hazard ratio, they obtained 2.31. This slide is showing the Kaplan-Meier curves for task C and D patients. And of note, there's an increase in mortality signal at 4 months, and then again at 18 months. Some of the limitations identified by the authors of this study, they did not investigate the cause of mortality. It was a single center retrospective study design, which obviously the study exposed to selection bias, external validity, sample size, and blinding issues. The observational nature of the study may lead to unmeasured confounders, and the small sample size and low event rate led to wide confidence intervals. And the effect on treatment on main outcomes may be under-detected. In summary, for patency, the use of the paclitaxel-eluting stents did not result in a greater overall 2-year patency compared to bare metal stent. And as well, when you looked at TAS 2A and B or TAS 2C and D patient subgroups, there was also no difference in patency between the two groups. As far as limb salvage, the use of paclitaxel-eluting stent did not result in a greater overall 2-year limb salvage rate compared to bare metal stent patients. And this again was when they subdivided into task 2A and B and task 2 and C and D, they also did not see a difference in limb salvage. As far as mortality, there's no difference in overall 2-year all-cause mortality for the bare metal stent and paclitaxel-eluting stent groups. There was a almost 4 times greater increase in all-cause mortality at 2 years for those patients that had TAS 2C and D lesions. This was of significance. There was a 2-time increase in all-cause mortality at 2 years for a subset of patients with TAS 2A and B lesions. This did not receive a p-value of significance. So in conclusion, there was a 2-fold adjusted hazard ratio increase in all-cause mortality at 2 years for a subset of paclitaxel-eluting stent patients with TAS 2C and D lesions. The authors were unable to explain mechanism for increased mortality in this subgroup, unable to show benefit of paclitaxel-eluting stents in regard to patency of the femoral popliteal arterial segment and limb salvage as compared to use of bare metal stents. Further research is needed to address this complex issue regarding the use of drug elution for peripheral arterial occlusive disease. I want to congratulate Dr. Mathlouthi and Dr. Malas on a great paper, good opportunity for me to review. I just want to finish with some questions I had when I was reviewing this paper. So I'm just going to go through that. Why was more detailed mortality data not obtained? How do you explain the increased mortality in the bare metal stent TAS 2A and B subgroup of patients as compared to patients undergoing paclitaxel-eluting stents? How do you explain lack of benefit in the eluting stent patients and increasing patency and limb salvage as compared to patients undergoing bare metal stents? What do you recommend to your patients with femoral popliteal arterial disease, bare metal stents or paclitaxel-eluting stents? How do you prove a dose-response relationship going forward? And finally, what specific research do you recommend going forward to address the complex issue regarding the use of drug elution for peripheral arterial occlusive disease? Thank you.
Thank you, Dr. Khan. You have a lot of questions up there. Maybe you can leave your slide up for just a minute and we will have Drs. Mathlouthi and Dr. Malas make some comments just on these questions to start.
Okay. Hello, everyone. Thank you so much for this amazing discussion, and we are honored to be here with you tonight. Well, I'm going to start with the first question about the more detailed mortality data. Why was it not obtained? When we collected the data, we were back at Hopkins, and honestly, the main focus of the study was to be about patency. So we did not, at the time of collection, we did not capture the cause of mortality. And then when we did the analysis and found this increased mortality among task C and D, then it just happened that we all left Hopkins, so we don't have access to that data anymore. So we cannot just go back and capture that data. And it's a limitation of our study. And yes, it will be very interesting to know all of the causes of mortality. Regarding the second question about the task A and B, I personally, honestly, do not think there is a difference because the P was 0.8. And with this small sample size, that was just a couple of patients more difference. So I don't think that was a significant difference. So yeah, that's it. When it comes to the lack of benefit of paclitaxel-eluting stents in patency and limb salvage, it is true that we have multiple randomized trials now showing that there is better primary patency and freedom from target lesion revascularization with paclitaxel-eluting devices, including the Silver PTX, the Thunder trial, the Impact trial. However, all of these trials excluded patients with task C and D lesions, and some of them even excluded patients with tissue loss. whereas in our cohort, we see that we have 53% patients had CLTI and 23% of the patients had task C or G lesions. Now, there is this registry that was created, the STELLA PTX registry, that was only for patients with task C and G lesions. And they implanted paclitaxel-eluting stents in them. And then it ended up not achieving its goals when it comes to primary patency and to target lesion revascularization, with a primary patency rate at 1 year of 53% and around 40% rates of in-stent stenosis and thrombosis at 1 year. So they stopped that and they decided that it just did not achieve its goal in these longer, more complex lesions. We think that this might be an explanation of the lack of difference in primary patency, because our cohort and in this real world setting, it was patients with very long complex lesions. Regarding the recommendation to the patients, well, I'm not a surgeon yet, so I would like to leave that to Dr. Mattos to answer, if that's possible.
The how to prove that.
No. What do you recommend to your patients with fempop arterial disease?
Yeah, and I saw also Keith had in the chat, do you talk to your patient about increased mortality, in the clinic when you're going to put a drug-coated stent? I mean, just first, thank you again for inviting us, and great to be here with you guys. This was awesome, beautiful discussion, very stimulating. Esma, congratulations again, great work. She's done an amazing job, and she's applying to vascular surgery, guys, next year. So remember her. She will be an asset to any of the programs she joined. I had the opportunity to mentor her. I was very lucky to have her on my team. Very, very interesting about this paper. Before the meta-analysis, the very first meta-analysis came out about increased mortality with drug-coated technology. One of the projects that I was working on with Esma at Hopkins, I said, let's look at, the patency of drug-coated stents versus, bare metal stent and versus bypass. And Esma called me and she said, you know what? I'm finding an increased mortality with drug-coated stents. I'm telling you, honest to goodness, this story. This is before the first meta-analysis came out. And I told Esma, something is wrong. You're doing something wrong. Go back and look at it. There is no way there's increased mortality. Full disclosure, I was part of the IDE study that led to the approval of the Zilver PTX, and I was part of the post-approval study. So I said, no, go back and look at it. And she looked at it and I looked at it, and we had another person look at it, a different, unbiased person. And we found the same outcome. And then within 2 days, the meta-analysis was published and was on every news outlet. And I actually got it on Twitter and I sent it to Esma, and I'm like, you won't believe this, but you found, look at this meta-analysis showing increased mortality. So this is how this whole thing happened. And then we start focusing. We thought maybe we can make it unique because we're finding the increased mortality is more pronounced in the longer lesion, when we thought maybe because more dose or having more than one stent. So, but honestly, when all this stuff came out, I stopped using drug-coated stents, just to be, put it out there right away. So how do I manage these patients? I don't really use drug-coated stents anymore. And I know this is still very controversial, and there's a lot of conflicting data in different directions we listened to today. But in my mind right now, I don't really see a very strong evidence to justify using drug-coated stents, even if there is a slight increased risk of mortality, especially that the improved patency is not that huge. And just like Esma was mentioning, there is really, at least in real life data, there is no difference in patency that we were able to replicate from the clinical trial. And again, it's the same story. Clinical trial, super selective, perfect patient, shorter lesions, and then you're going in and trying to do the same thing for, longer lesion with a lot more complex, extensive disease. So that's just to answer that question.
So there's a lot of questions that have come across in the chat. So Dr. Khan, we'll have you stop sharing your screen, but we also have our special guest, Dr. Peter Schneider, who is also on the call. And I was hoping that he would unmute and maybe make a couple of comments.
Yeah, hey, thanks for inviting me. That was great, very interesting. Dr. Khan, nice analysis. I think, Dr. Malas and I were friends, so if I'm a little critical, he won't mind. But honestly, this paper was submitted in January 2020. It's like, might as well be 10 years ago, just based on how much information has come out since then. Just in this past month and a half, SwedePad and Voyager, both RCT situations that showed no difference in mortality. I think, it's smart that in the institution where they got this data. They said, hey, we need to look for ourselves. And I think everybody needs to do that whenever they can. If you have an institution that's done a lot of this type of work and then it comes under some impression that you may be doing harm, I think looking for yourselves makes a huge amount of sense. But the truth is, this is, I think, no one's really mentioned the selection bias that goes into this. And although, there was more CLI, 60% versus 45% in the TASC C&D paclitaxel stents, even if you just project the 2-year mortality for CLTI and claudicators versus CLTI in that TASC C&D group, it kind of simulates the increase in mortality that you get. So, I think it suffers from small numbers, and that's the problem we all have when we look at a small institution study. But I think the real issue is this. If there's a causal relationship, there has to be a dose response. And if there's a dose response and you have the patient level data from your institution, I would have recommended pulling the charts, looking at what stents they got, how big they were, what length, what diameter, and calculating the dose. Then you could have had a much bigger number. You could have included from task A through D, and you could have looked for cut points in mortality to see if there was a rising mortality. And at the same time, there was one analysis prior to your submission and 3 analyses since that show no dose response, no connection between the amount of paclitaxel and the degree of mortality. So, and those were patient level analyses rather than retrospective indirect evaluations. So, I think this is a piece of the puzzle. It makes sense to look at your own data. It makes sense to try to look and see where it fits in the context of the bigger, wider world out there. I don't think we can solve this just by looking at big databases. I think patient level information is super important. And this, to some degree, even though it's retrospective, this is patient level information, so it's useful. But I think the numbers are just too small and the selection bias is too great in order to make much of it. It's just, again, another piece of the puzzle.
What about the patency difference, Peter?
I think Dr. Malas should stop using drug-eluting stents right away because it doesn't look like there's any advantage. It may be that there may not be as much advantage in this population. That's the thing. That's why it's worth looking. But again, this is more CLTI, more limited runoff, more chronic kidney disease, more congestive heart failure. Those are the 4 things that I really don't want if I get sick. And all 4 of those things were in a higher prevalence in the paclitaxel-eluting stent group. So I'm a little bit torn on how to interpret that, Peter, but it's a really good question. And I don't think we can take the results of patency in these very, and Mahmoud mentioned this and I agree very much that the RCT population, we screen 10 patients, 20 patients sometimes to find someone that will enter into an RCT. We work hard to limit the variables, but it doesn't really help us with the bigger, wider world very often. So that's why I applaud your efforts to look at your own data, see what you got.
Hey, Peter, Mark here. Nice job. Question is, do you think the completion of the current RCT trials will answer the question, or do we need to go to another trial, a national trial here in the United States to figure it out?
That's a really good question. And, you know, obviously that won't be up to me because that's another $40-50 million proposition. I will say a couple things. One is that we now have SweetPad and Voyager, which I mentioned. We also have 5-year data now from all the pivotal RCTs. The 5-year data from Illuminate was just presented at Link about a week and a half ago. And I'm working with a group out of Australia, out of Sydney, Ramon Varco and his group. And basically, since that Illuminate data was presented, what we did was we took all of the RCT data, now out to 5 years, for pivotal trials in the US, and we replicated Katsanos' steps. We did the exact same things he did as described in his well-written manuscript, and the signal goes away, basically. It doesn't mean there's no signal, because there may be some in certain populations. There may be some risk in certain populations that we can't identify with that. But at least from a standpoint of what we got 2.5 years ago in that meta-analysis, I think, you know, he was right to identify something because there was something there. But it looks like with the more data we get, the less impressive it seems. So I think in that light, I would be shocked if anyone, I think probably make more sense to put $40 or $50 million into sirolimus-eluting devices, which is, I think, probably what will happen. And paclitaxel has downsides. It's never been shown to work below the knee, except with coronary DES in very short lesions. That's a pretty big downside because most of the below the knee lesions we all treat are very extensive. We, you know, multiple failed paclitaxel trials below the knee. So, you know, we'll have to see what happens there. But I think for SFAs, I think, honestly, I think the risk is way overblown, my personal opinion, based on what we know now. But there may be still some risk that we haven't clearly honed in on.
But the sirolimus feeder was already kind of tested before, right? And didn't really show benefit.
Well, sirolimus has failed 3 times in the SFA, right? Sirocco, Strides, and Stroll. And paclitaxel, honestly, for patency, at least in the RCT setting of a DCB above the knee, has set a pretty high bar. You know, you start talking coronary level patencies when you get up, you know, the most recent Illuvia versus Zilver was, you know, 89% versus 79% patency at 1 year. That's pretty good. That we're getting close to coronary level. So it's a high bar. It'll be a big competition. You know, we'll see what happens. More to come. I don't think there's going to be, we're not going to squeeze any more out of the 5-year pivotal data because Illuminate was the last one. So if FDA stays quiet for the next 6 months, despite SweetPad, Voyager, and Illuminate, then you know that basically paclitaxel is maybe gone forever. I have a feeling they'll say something though, because I kind of think they have to, based on the fact that the risk profile is so much different than what was initially suggested.
Peter, we've heard this the basic science article and then this article, and you know, is there another drug class that's going to be coming down soon that you might know of or that you could shed some light on where we're not going to be using these particular drugs anymore?
You know, I'm not aware of anything. You know, Abbott now is enrolling the Life BTK stent. You know, it's a bioabsorbable vascular scaffold. That's everolimus. It's not a different class, but you know, obviously everolimus and zodorolimus have emerged in the coronaries as maybe the best, you know, sort of best they have. The big problem, and Mahmoud is right, Limus fails without a delivery vehicle. It is not easily transferred to the wall of the artery. So with DES, it makes sense if it can be done properly. And there are a lot of ideas about it. There are about 6 startups. There's a company called Med Alliance. It's out of Switzerland. They've got 2-year data in the SFA, and the way they attach it's a DCB. The way they attach the sirolimus is with a nano encapsulated particles. You know, you may have seen something about that. The challenge for that company is they're trying to do coronaries, SFA, and BTK all at the same time. So once again, we get short shrift in the non-coronary arteries. You know, if they can manage all of that at once, which is tough for a startup, then we'll benefit because we'll get the science and we'll understand if sirolimus has a good opportunity in the lower extremity, at least in SFA.
Hey, Peter, in all the reviews, it's all about mortality and it's all about patency. Where does cost effectiveness come in? Because the drug-eluting balloons and stents are much more expensive than the bare metals. At some point, where does that figure in terms of the clinical discussion with the patient, or maybe even with the insurance company at some point, or does it?
Well, there have been some cost effectiveness studies, but they're all sort of based on the results of the RCTs. And I think the bottom line on cost effectiveness is that if we are eliminating repeat procedures, that we are reducing overall cost. But if we're not eliminating repeat procedures, or let's just say the patient gets a recurrence but wasn't going to get a repeat procedure or any of the other things that could possibly happen, then the argument kind of falls apart. I will say, though, that if you think about what we can offer to a patient, if you think about somebody, you go to buy a new car and, say it's a $20,000 car or whatever, and the guy says, oh, yeah, it'll last you at least 6 months for sure. But by 1 year, not so sure. And yet that's kind of where we are with bare metal stents and plain balloons. I think, and I don't know, I'd be interested in Mahmoud's opinion on this, but, despite the results that you found in that task C and D group, I have the impression from all the RCTs and everything that there is a patency benefit, a benefit in efficacy. That's my impression. Again, given all the vagaries of the RCTs and everything. And if you think about, let's just say for a minute that if bare metal stents and balloons is 50, 60%, and in the same population, it's 70, 80%, it's hard to think of another thing that we could do other than really, really good medical management that's going to lead to that kind of incremental benefit. And so, and people have tried all kinds of things from brachytherapy to, you name it, it's been done somewhere if you include the coronaries. And drugs seem to be the thing that leads to that big incremental improvement. The reason why the Katsanos thing was so important, in my opinion, wasn't that, somehow we were going to save lives if we stopped using paclitaxel, but whether his assessment was correct or not, the value of what we could provide to patients decreased by 1/3 overnight. If you think about the patency of the procedures that we're doing. And so that was a big slap in the face. I know everybody's worried about liability. If this were really happening, people would be getting sued left and right. And every time you look on the internet for paclitaxel, the first 10 ads would be lawyers. And that's what everybody was worried about. And that didn't happen. There's a reason, because we're having trouble finding the connection.
Oh, I agree, Peter. I think, the big picture for us as vascular surgeons, number one is like, why are we treating these patients? And a lot of them probably don't need anything except best medical management because they're claudicating. And if we decide to do something, there's a huge difference, I think, between critical limb ischemia versus, claudicant, because very, very different, obviously, problem patients and very different goal of the treatment. So if a stent saves someone's limb from an amputation and then the stent goes down, who cares about the patency? The outcome should not be patency, the outcome should be limb salvage. Obviously, when we're looking at claudicants and the stent goes down, it's a huge deal because they're going to have their symptoms back where we started. So then, so I think, that's the problem. And if you look at the majority of clinical trials, unfortunately, they focus on task A and B. There are a few exceptions. And, like I said, I was part of the IDE for Zilver PTX and for the post-approval. And I probably had more number of C and D than any other clinical trials. But, this is, there's two different things also. There's the, the patency, and then there is the mortality. And these are totally different things. And it's not just us that we didn't see a benefit. There are many institutional studies that didn't really show this huge difference in patency. And again, maybe, like you said, it's patient factors. When you start, putting the dialysis patient and the horribly uncontrolled diabetes and the really long lesion, you're not going to find this benefit maybe. And that's what we see in real world data. The mortality, I agree with you, is very conflicting, but there's no question about it. Like the utilization of drug-coated stents have gone down to nothing almost. And that's just, I'm sure you agree with me, that's what's happening in real world. So clearly with vascular surgeon at least, and even other specialty interpreting from this data, is they don't feel comfortable using this technology, even though they, the study that you mentioned, Peter, that have showed no signals or no difference. But what's happening in real world is that people are really not using it anymore. So, and finally, I totally agree with you. We have nothing really good for task C and D, at the end. And maybe the drug-coated is the one that showed one of the better patency. And let's not forget that we're a surgeon and we can do awesome bypasses too that has very good durability and very good patency long term. So I think that's also one piece that we haven't talked about at all. That's major part of the picture.
I was going to say, Mahmood, we do have a good thing for task D, and that's a good vein. So thank you for bringing that up. That's super important for our trainees to hear. Yeah,
we always focus on all these different technology, and we forget what makes us unique is not the fact that we can use this endovascular techniques. I mean, any interventional cardiologist or geologist can do this. What makes us unique is that we can do amazing bypass that works, and no other specialty can compete with us on this. That's one of the things that I always tell my trainee, you do carotid, you have 3 different specialty competing with you. But when you get to even aneurysm, thoracoabdominal, you have other specialty. But when you get to bypass, really we're the only specialty who can take 3 pieces of vein and put them together and go from fem to the toe and save a limb. And that's what we need to focus on as vascular surgeon, I think, at the end.
Mahmood, that was a great, I think, conclusion to our discussion tonight. I just want to thank everybody who is on the call for their participation. The level of expertise here is awe-inspiring, and I'm glad I'm participating because I'm learning a ton. And I hope the same is true for everybody. It looked like Matthew Smeds has 10 people in his room. Is that true, Matt? Good job, you guys.
Social distancing, Matt.
Thank you, Pete Levitsky. Thank you, and everyone who presented. Wonderful job. And we hope to see you again in March. All right. Have a great night, everyone.
Thank you,
Paul.
everybody.
Thanks, Misty.
Thanks much.